Good morning all. Today we are going to talk about fixed dose combinations and rational use of drugs. This is one topic which is relevant at the beginning of the third semester also, and it remains relevant at the end of your fifth semester also, or the end of pharmacology curriculum also, and at some places it is again covered in during your internship also. Reason being that this is fixed dose combinations and irrational use of drugs are very rampantly followed without any logic most of the times, like you would see in the prescription or a animated prescription that's on the right side of the presentation, where you would see a lot of antibiotics have been prescribed. A lot of antibiotics have been prescribed for some condition. Then there are 5 non-steroidal analgesics that have been prescribed and 4 vitamins have been prescribed. So this is a classical example of a polypharmacy, or prescribing too many medicines when they are not required. So this is irrational prescribing. And then you would probably not know if this NSAID has some other, whether it is prescribed as a single drug or it is prescribed as a combination. Most of the times what happens is we are driven by what the medical reps tell us. It looks very uh, rosy, so to say, and then we prescribe. The brand name would be very catchy and you would prescribe the brand name, and you would not tend to remember what is the exact composition of that brand name, whether the particular patient requires it or not, right? Like William Osler said, good physician treats the disease, great physician treats the patient who has the disease. So you're not treating a condition, you're treating a person, and that's the rationale behind rational use of drugs. So I'll begin with fixed dose combination. It is defined as a combination of 2 or more active ingredients in fixed ratios of doses. It may be administered as a single entity products given concurrently or as a finished pharmaceutical product. By this I mean it is either a co-packaged drug wherein 3 different drugs are packed together for convenience, or in a single tablet or capsule itself there are 2 active ingredients. Traditionally, by default, this is taken as a fixed dose combination. Like here we have, in this example that I have taken, we have amoxicillin and potassium clavulinate, which acts as a penicillinase inhibitor and prevents degradation of amoxicillin in penicillin resistant organisms. So these 2 drugs are combined into a single finished pharmaceutical product. So this by default means FDC, that is 2 ingredients in the same product. This in India is called as co-packaged drugs. That means this is a kit for H. pylori infection wherein a PPI is combined with 2 antibiotics. So the 3 drugs are there in one package. So one capsule would have one ingredient, the other tablet would have the second ingredient, the third tablet would have the third ingredient. They are not into the same tablet. 2 or 3 ingredients are not there in the same tablet. So this is a co-packaged formulation. Broadly speaking, this also falls under the fixed dose combinations. Now, why do we need FDCs? Fixed dose combinations, they increase the efficacy. For example, we have 2 antibiotics. This you may not be able to remember the names or maybe not understand all the examples that I'm going to talk about, but when we go back to revise the topic in 5th semester, then you would be able to correlate more. For now, it is important for you to understand the concept behind the examples that I'm using. So when I say FDCs may increase efficacy, I mean that in this example, sulfamethoxazole and trimethoprim, they act on 2 subsequent steps of folate utilization in the bacteria. Individually, both these drugs are bacteriostatic, But when used in combination as co-trimoxazole, they become bactericidal. So that's increasing the efficacy. 1 plus 1 here becomes 3. Then because you're replacing 2 tablets with 1 tablet, it tends to increase the patient adherence also. It reduces the toxicity. For example, when you combine levodopa with carbidopa, carbidopa inhibits the peripheral metabolism of levodopa to dopamine, thereby reducing its peripheral adverse effects, and more dopamine is available in brain for the Parkinsonism patients. Since more dose becomes available in the brain where it is required, the dose also reduces for levodopa by combining it with carbidopa. So that's also an advantage. The side effects would reduce. Then resistance. Classically, anti-tubercular drugs and anti-HIV drugs are combined together so that Mycobacterium tuberculosis is known to develop rapid resistance. If you give isoniazid alone, even if it is bactericidal, the organism would develop resistance before it is cleared out of the body. So a multi-drug regime is used for treatment of tuberculosis to reduce resistance and thereby increase efficacy also and shorten the duration of complete treatment, thereby improving adherence and reducing administrative or logistic costs. Making FDCs also at times simplifies the regime. You have to take one drug, BD, you have to take one drug once a day. Patient would need to remember, but if you co-package the drugs by saying morning 3 drugs are co-packaged together, evening 1 drug is color coded separately, that simplifies the regime. So these are the advantages and reasons why FDCs are at times preferred. Why FDCs should not be made? If there is any physicochemical instability or incompatibility, that means if you mix 2 drugs, they would interact physically. There would be structural incompatibility and they would inactivate each other, or chemically they would inactivate each other. That makes it difficult to combine into one formulation. Then there is a pharmacodynamic mismatch. For example, one drug is increasing blood pressure and the other drug is reducing blood pressure. You combine the 2 drugs to market it as a anti-hypertensive drug. It would be antagonizing each other's effect pharmacodynamically speaking. Then there could be pharmacokinetic mismatch. Going by half-life of the drugs, one drug is to be given 3 times a day, but the other drug is to be given only once a day. If you try to combine these 2 drugs into one finished formulation, would you give the formulation once a day or twice a day? So that becomes a pharmacokinetic mismatch. And then adverse drug-drug interactions. Both the drugs that you're trying to combine, they act on same receptor, they produce similar adverse effects. So the toxicity is getting compounded, or one is a cytochrome P450 inhibitor and the other is a substrate. So the second drug is going to cause toxicity. So that's adverse drug-drug interaction. These are some of the things pharmacologically speaking that you need to look into before an FDC is developed. Finally, we come to cost. Is cost important for development of FDCs? Absolutely. But is it always given due importance? With some riders. What riders? Like for example, I mentioned amoxicillin and clavulanic acid. The combination is much more costly than amoxicillin alone. Amoxicillin is an old time-tested drug. Preparing clavulanic acid is more expensive, so the combination becomes more expensive. Yet it is a desirable combination. Why? Because amoxicillin alone, lot of bacteria are resistant to penicillin group because they develop penicillinase enzymes. Clavulanic acid inhibits that enzyme, making making the bacteria susceptible to amoxicillin again, which means you don't need to go into reserve drugs like linezolid, right? So the old drug still becomes relevant. So that's how it is a desirable combination. But then let's take another example. Steroids and antifungals are very commonly combined, especially in skin preparations. Creams and gels topically to be used topically. These combinations are cheaper than the total cost, but they are not desirable. They would, for any given skin condition, either it would be steroids that would be required at any point of time, or it would be the antifungals. Together, their requirement would be very rare. You would have to, if there is a requirement for both, you would have to first suppress the fungal infection, then give steroids, because steroids would lead to immunosuppression and a flare up of any kind of infection. So this kind of a FDC is not desirable. So once again, should cost be given any importance? Yes, but only when the rationality is established. And when I say rationality, you look at these factors and these factors. So whether there is any mismatch is there, or it is going to increase any drug interactions, so you look at the pharmacology of the drugs, and then you look at the benefit or potential benefits of the proposed FDC. If the benefit is not significant, but the mismatch is significant, that means the FDC is not rational. So rationality needs to be established before you prescribe an FDC. Then there is another condition where rationality is compared with reason. Like I mentioned, anti-tuberculars and anti-HIV drugs. I've taken two examples of tuberculosis combination for anti-tubercular drugs like ethambutol, isoniazid, pyrazinamide, rifampicin. Isoniazid is H, rifampicin is R, pyrazinamide is Z, ethambutol is E. So this combination has HRZE, which is the first line treatment for susceptible pulmonary tuberculosis. So this combination, this is usually a co-packaged drug, not per se an FDC, but this combination would be useful for a particular class of patients. In India, tuberculosis is very, very rampant. It is a disease of national importance. So the combination becomes important. Even if there are pharmacokinetic mismatches, like rifampicin is to be taken empty stomach, isoniazid is to be taken post meal. Some of these drugs would be once a day, some would be twice a day. So there is a mismatch here, pharmacokinetically speaking. So they cannot be superimposed, but still the combination is desirable because it simplifies the regime, improves the adherence in a disease of national importance, which would have indirect sequelae in the sense that if a patient takes drug regularly, he is likely to become sputum negative fast. He is less likely to transmit disease to others, thereby reducing the national load of disease. Similarly, for HIV, lamivudine, nevirapine and stavudine are drugs for HIV. HIV patients, especially if they develop AIDS, they would be on several drugs for treatment of HIV also, for treatment of opportunistic infections also. So their regimes get very, very complicated. To simplify the regimes and to prevent resistance, it is important to co-package these drugs, or where possible prepare FDCs in one pharmaceutical preparation, so that these drugs, the regime is simplified, improving the compliance. So that's rationality versus reason. So tuberculosis, I've specifically taken example for tuberculosis and HIV because these are nationally important diseases. These are some of the examples of most common fixed dose combinations available in the country. You would see lots and lots of preparations for vitamins and minerals, but when you look at their composition, the amount of each vitamin, you would notice that most of these preparations are meant only for prophylaxis. They are not meant for treatment of a particular condition. It is different types of anemias are unlikely to coexist in majority of the population. Zinc deficiency would be there, but maybe B12 would not be there, or maybe magnesium deficiency would not be there. So if you are giving a multivitamin or multimineral preparation to a patient who has deficiency of zinc, you are wasting other ingredients and increasing the cost for the patient. Similarly, for cough suppressants, cough, cold and fever preparations, there are several cough suppressants, cough syrups. I've seen cough syrups with as many as 27 ingredients. So usually that is not required. Ideal would be to give paracetamol separately when there is fever, because paracetamol is to be used mostly SOS. If there is nasal congestion, you prescribe separately. If there is cough, depending upon the nature of the cough, whether it is dry cough or productive cough, what is the cause for cough, you prescribe a cough suppressant or an expectorant. This would be covered in details in subsequent classes. Similarly, there are several combinations with analgesics, including non-steroidal analgesics, steroidal analgesics, with muscle relaxants, with serratiopeptidases, plus may or may not have antacids or PPIs added to it. So these again are not really relevant most of the times. If it is a visceral pain, different analgesic would be required. If it is inflammatory pain, different would be required. Where a muscle relaxant is required, analgesic may not be required. Serratiopeptidase evidence is not conclusive on their efficacy. It only adds to the cost of the preparation. Antacids should be prescribed on a SOS basis unless the NSAIDs are to be prescribed for a long duration of period. Then you could add PPIs to the regime on and off. Then antibiotics, I've already mentioned, there are several combinations of antibiotics. There are combinations of this again would be covered in rational use of antimicrobials, which is again a separate topic, because antimicrobials are very rampantly combined when, even if they don't have overlapping spectrum of mechanism of action, overlapping spectrum of their activity, the mechanism of action and pharmacokinetic mismatch would be there, yet the antibiotics are co-packaged or converted into FDCs for prescriptions, so that the treatment can be done empirically without sending samples for culture sensitivity, which is a wrong practice and it increases the development of resistance. Then cardiovascular medicines, for example, Polypill was some time back developed for cardiovascular, secondary prophylaxis in cardiovascular patients for adverse cardiovascular events like MI. Then anti-diabetics are also commonly combined. Metformin is the most common drug, which is combined with other sulfonylureas like glibenclamide, glipizide, etc. Some of these combinations may be required, but then dose titration. Antidiabetics and cardiovascular medicines require frequent dose titration. Antihypertensives also are they require dose modulation, which becomes difficult if you're using a fixed dose combination. So if for example, if you prescribed a FDC of metformin with glipizide, now a patient is having hypoglycemia. That means the dose of glipizide needs to be reduced. But then if you reduce the dose of FDC, you would be reducing the dose of metformin also. Metformin does not cause hypoglycemia. It is meant to increase the effect of insulin and reduce the dose of glipizide. So dose titration becomes difficult when you're using such FDCs. So it is better to prescribe single drugs. There are, like I mentioned in the beginning of the class, there are several fixed dose combinations in the country, maybe more than 500 different types of fixed dose combinations, and then even if you have 5 brands for each combination, you would have 2500 fixed dose combinations in the country. And that's just a random figure that I've used. Maybe there are much more. So from time to time, different committees have been formed to look at the rationale of these fixed dose combinations and weed out what is not rational or what is irrational. So this is a report of one committee which was in some 2005 or 6 that the committee was set up. Then this is based on a COCATE committee which was recently set up, and it led to a huge UN cry because there were losses to pharmaceutical companies. But some of these fixed dose combinations have already been banned, some are pending in court. So, to summarize fixed dose combinations, one should this is basically these are the criteria based on which FDC, whether it should be developed or not, is to be decided. So you look at epidemiological considerations, whether the disease is very important nationally, wherein reason would be more important than rationality. Of course, there has to be rationality, but there is added reason to overlook some amount of rationality to develop a fixed dose combination. And then the patient's concerns and requirements in terms of simplification of the regime, in terms of administrative and logistic support. Like for tuberculosis DOTS program, it becomes a lot easier if the drugs are co-packaged. That means a, a peripheral healthcare worker or ASHA worker is not does not need to remember all the details. He or she just have to pick up a packet and give it to the patient, or pick up a box. These drugs come co-packaged formulations come as a box, which are for children categorized on weight basis, and for adults a complete box is there based on the category of the infection, the tuberculosis, and then that worker has just pick up the box and give it to the patient. Cost is the last consideration while deciding whether to develop an FDC, or so to say, the go-no-go decision to develop an FDC. Cost should be the last consideration, although it still remains important. Next topic is rational use of drugs. So far I talked about rationality of fixed dose combinations. So that's the rationality part of it. The rational use of drugs is defined as it requires that patients receive medications appropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time and at the lowest cost to them and their community as well. So important here is appropriate to the clinical needs. That means unnecessary prescribing is not there for antimicrobials or analgesics or vitamins, for example, in doses that meet their own individual requirements. That means you tend to remember the doses, and you need to remember the doses. You can't prescribe isoniazid one tablet. Isoniazid would come in 3 different dose strengths. So what is the strength that is required for that particular patient? Even in adult tuberculosis patients, they would have lost weight. So depending upon the weight, you need to prescribe the isoniazid. For appropriate periods of time, you can't really prescribe antimicrobials for 2 days or 3 days randomly. Depending upon the infection, the site of infection, the organism, you need to decide the duration of the treatment and at the lowest cost to them and the community. If linezolid is freely available at AIIMS, does not mean you are free to prescribe it even when amoxicillin would be sufficient. Even if it is freely available at AIIMS, somebody is going to bear that cost. That somebody in this case would be the government. Government is providing the linezolid free of cost to AIIMS. And where is government getting the money from? From the taxes that we pay. So ultimately it is our own money that's at stake. So that's why the community and the patient. This also inculcates prescribing by generic names. If you prescribe by generic names, then the patient the patient can go to the pharmacist and tell that this is the generic name, like omeprazole is to be given as a proton pump inhibitor. Now, omeprazole could be available for 10 rupees also and for 50 rupees also. If you prescribe as omeprazole, then the patient is likely to get the cheapest available brand. If you prescribe as Omaze, which is one of the brand names for omeprazole, then the cost for Omaze is 23 rupees. So that means the patient is paying more when a cheaper brand is available. Rational use. So this is just a summary or the other way of saying what I told you in the definition. That means the drug is prescribed for correct indication. For that indication, the drug is correct. Then consideration has been given to efficacy, safety, suitability for the patient and cost while selecting the drug. Once the drug has been selected, appropriate dose, route of administration and duration is prescribed, and there are no contraindications for that particular patient. After that, the drug is correctly dispensed, including giving appropriate information for the patient. For example, proton pump inhibitors work best if they are taken on an empty stomach. With food, their bioavailability reduces. Then you talk about then patient adherence to the treatment is also a part of rational use and is ensured by the uh, physician and the pharmacist also. Why this topic is important? Because now we have a drug explosion. We are spoiled for choices. Like I mentioned, there would be, for example, 10 PPIs available, and for those 10 PPIs, there would be 100 brands available. So, which one do you prescribe? That's a perpetual question that you're going to face once you start prescribing. Then development of resistance. There used to be a time when there were no antimicrobials before penicillin. Infections most of the times used to be fatal or at least high morbidity. So that was considered a pre-antibiotic era. Now we are heading towards a post-antibiotic era wherein the resistance is becoming so rampant that we don't have, despite having so many antibiotics, there is none effective. There are several infections, especially in ICU setup, you would see several in patients where there is no antibiotic or the antimicrobial available is so toxic, but there is no choice but to give that antimicrobial. So that's the stage where we are heading. And then by doing all this, we increase the cost of treatment, like I've already talked about with brand and generic prescribing. What helps you to prescribe rationally is evidence-based medicine. Evidence-based medicine looks at the best available clinical evidence in terms of the literature, the research that has been done. It looks at patients' values and expectations also, and individual clinical expertise also. But the focus is on best available clinical evidence. The therapeutic evaluation of a drug based on available evidence in terms of benefits, dosage, duration, patient selection, comparison with other drugs, and adverse drug reactions. So all this goes into the best available clinical evidence, and it gives lesser importance to individual expertise and patients' expectations. So follow evidence-based medicine or evidence-based prescribing, and you are more likely to be rational in your approach towards drug prescribing. Then you also have something called as standard treatment guidelines. Every country or every region has some standard treatment guidelines. These guidelines, they look at the most important or most prevalent disease conditions in the area, and they prescribe or give recommendations on the drugs that need to be prescribed and in doses and duration that needs to be prescribed for that condition. It would give treatment guideline as first line treatment, first line of preferred treatment, and second line or alternative treatment. So that way you don't have to do this exercise of looking at all the evidence yourself and then evaluating. This evidence goes into the formation of standard treatment guidelines, and it simplifies the on-table prescribing for physicians. Why do we need STGs? Like I mentioned, you don't need to evaluate everything yourself all the time. You have a ready reckoner with you while you are prescribing, and you need not remember all the best treatments and their doses. Then there's something called as essential drug list. These are the drugs that satisfy the needs of the majority of the population. They should be therefore available at all times in adequate amounts and in appropriate dosage forms. When I say majority of the population, would tuberculosis be a problem of the majority of the population? Yes, it is. Would Gaucher's disease be a majority's problem? No, it is not. So, for a patient of Gaucher's disease, enzyme replacement would be essential. But when you look at the larger picture or at a national level, Gaucher's, though it requires some government support, but it would not find place in the essential drug list. So it would come under the category of rare diseases, and there are different programs for rare diseases. We won't go there. That's about majority of the population. Now that tuberculosis we have decided is a majority problem. That means anti-tubercular treatments need to be available at all times, at all places, in adequate amounts. So if we are a population of more than 1 billion, so if it is a problem, when we say majority, we say at least 70% population. So you need to be at AIIMS, how many patients are coming, accordingly you be prepared for availability of these drugs in adequate amounts at all times and appropriate dosage forms. By which I mean you should have syrups also for children, you should have tablets or capsules also for adults. So dosage form is also important, and probably for tubercular meningitis you should have parenteral preparations as well. So depending upon a PHC may not have parenteral preparations for tuberculosis, but it should have doses for adults and children. A tertiary care center like AIIMS, it should have anti-tuberculars in all dosage forms and adequate amounts. Do not let advertisements block your intelligence. Like I mentioned in the beginning, we, when sitting in clinics, at times rely on the information that is given to us by the medical reps. They would tell you all rosy things. That's their job actually. I won't blame them. It's their job to market their product. It's a competitive market. Several companies are preparing the same molecule. So how do they increase their own sales? They give the drug a flashy brand name that's easy to remember. They tell you all rosy things about it. And somewhere in the fine print they mention the adverse effects or the precautions also. So it is important that you read this fine print. For example, they would tell you the drug is 10 times more potent, and in the fine print it may cause some renal damage in some patients. So you need to know what is the some patients in which there is renal damage likely to happen. 10 times more potent may not mean anything. Instead of 10 gram you would be giving 1 gram, 10 milligram you would be giving 1 milligram. That does not mean much if the renal damage is significant. They may say it is the most effective antibiotic, but then for what condition, at what cost, and for what duration? So these are examples of some questions that should come to your mind. I've taken here an example of acifloxacin, an exciting discovery in antibiotics. There has been no new antibiotic in last several years. For tuberculosis, bedaquiline a couple of years back was the new drug with a new mechanism which came after some decades. So that's how dry the antimicrobial pipeline is. So always read the fine print and do not let advertisements block your intelligence. Ask questions and then prescribe rationally. Another important part of rational prescribing is good prescribing practices. which is right drug in the right dose, in the right formulation, at the right frequency, for the right duration of time. You would be in some pharmacology practicals, you would be asked to write prescriptions. So these are the components that should be there in a good prescription: the drug, the dose, the formulation, frequency, and duration. For example, take drug is omeprazole, dose is 40 milligram, formulation is capsule, frequency is OD, duration is 5 days. So capsule omeprazole 40 milligram once a day for 5 days. That's how you prescribe the drug. Do not skip on any of these and you would be making an error. Then good prescribing is not just matching the disease and the drug, it is individualization of the therapy. And it may include not prescribing drugs at all also. So no prescribing or no drug could also be a good prescription. What are the steps involved in good prescribing practices? There are 6 steps involved. I'm just going to enumerate these steps. There would be a separate practical class where case studies would be taken to help you select the drug for a particular patient. First step is to identify the patient's problem and recognize the need for action. So patient's problem is the indigestion. You recognize that indigestion is because of the acidity. The patient is overproducing gastric acid, and there is a need for action. You define the diagnosis. Then you list possible interventions or treatments, which could be drug or no drug. If it involves drug, then you identify the P drug. P here stands for personal drug. It means it is personalized for patient, or it is also personalized for or preferred drug for you for that particular condition in those types of selected type of patients. So this is the P drug concept, wherein consideration is given to efficacy, safety, suitability, and cost. You look at 4 factors. First, you select your P class of drugs. If you're talking about, let's say a patient comes to you with angina, what are the different classes of drugs that could be prescribed? Classes would be, let's say, nitrates, beta blockers, calcium channel blockers. You could add 1 or 2 more classes also which are relevant. Then you, based on efficacy, safety, and general suitability, you select your P class of drugs. Let's say you give due importance or due weightage to all these factors and you finally select nitrates as your P class of drugs. Then amongst nitrates there would be glyceryl trinitrate, glyceryl mononitrate, and dinitrate also. So you have 3 nitrates that you could use. From these 3, again you do the same exercise. You give due importance to efficacy, safety, suitability for that particular patient, and then cost. And then you finally arrive at for acute angina, you're most likely to come to GTN. So you give GTN for treatment of acute angina. That becomes your P drug for treatment of acute angina in a healthy adult male with no other comorbidities. If that patient comes with renal disease, then you may arrive at a different drug, again going through the same process, or you may come to GTN again. So that becomes your P drug for that specific condition in the patient. Now once you have identified your P drug, 4th step is to start the treatment by writing an accurate and complete prescription with name, dosage form, dose schedule, and duration of treatment. Then Fifth step is to give proper information, instructions and warnings regarding the treatment to the patient. That means you explain to the patient the dosage or the frequency of use, the adverse drug reactions, if there are any dangers or risks of stopping the therapy suddenly. You explain all that to the patient to improve the adherence. That also forms the part of the good prescribing. And then lastly, you monitor the treatment. It could be a passive monitoring, which is done by patient himself. You explain the patient what to do if the treatment is not effective or if there are too many adverse effects. Or it is active monitoring, wherein you give the next appointment to the patient to see if the drug is being effective or not, or if there is any need for dose titration or for stopping or changing the treatment. That is active monitoring. So these are briefly the steps involved in good prescribing. Now looking at some examples of irrational drug use. These are use of drugs not related to the diagnosis. So there is some hypoglycemia, but you've not either diagnosed it properly, or you've diagnosed it properly but you prescribe beta blockers. Beta blockers would mask the symptoms of hypoglycemia, so patient would not know it, but it would not act on the underlying pathology. Or you use incorrect route of administration. You give some drug orally when it is not absorbed. It gets degraded in the intestines. Or you give incorrect dose or incorrect duration is used. Polypharmacy is very frequently followed, and usually it is when you are not confident on your knowledge and you tend to overprescribe. Then unnecessary use of expensive medicines when cheaper alternatives are available, injudicious use of antimicrobials, unsafe use of corticosteroids, and unnecessary combinations or FDCs. These are all considered under irrational drug use. What happens because of irrational drug use? You reduce the quality of the treatment, thereby increasing the morbidity and maybe mortality also. There is wastage of resources, which reduces the availability for other patients and increases the cost for the patient to which irrational drugs have been prescribed irrationally. You increase the risk of unwanted adverse effects and may lead to drug resistance also in case of especially in case of antimicrobials. And then there are indirect psychosocial impacts, like patients rely on unnecessary drugs, which is very frequently seen because patients come to you with an expectation that you would prescribe something. If you send back the patient without any without any drug but with only counseling, patient may not come back to you. So the patient expectations are more, and especially in private practice, you need to fulfill those expectations also. So the balance has to be stricken for such conditions. But if the patient is not treated, patient would lose faith in physician and will not come back. So these are the psychosocial impacts of irrational prescribing. Like I mentioned earlier, antibiotics are most commonly prescribed drugs, and 70% of these are unnecessary according to some studies. How antimicrobials have led to antimicrobial resistance. Malaria was initially sensitive to chloroquine, and chloroquine was very highly effective for malaria. Even a single dose of chloroquine would lead to disappearance of parasite from the blood, and symptoms would subside, and that's precisely the reason why chloroquine resistance developed. The blood would clear, but the parasite would still be there, and eventually there would be selection of the resistant parasite, leading to a condition now that malaria has widespread resistance to chloroquine. Chloroquine is no longer effective for especially falciparum malaria. Tuberculosis started from being single drug sensitive to multiple drug sensitive to one drug resistant to multi-drug resistance, or MDR, to XDR, which is extensively drug resistant tuberculosis. There is some small portion of patients, especially in some certain pockets of the earth wherein the patients are resistant to all known antitubercular drugs. Gonorrhea used to be penicillin sensitive, but gradually it has also become resistant to penicillin. It is now called PPNG, penicillinase resistant Neisseria gonorrhoeae. Then pneumonia and bacterial meningitis are also penicillin resistant, and there are drug resistant diarrheas also. Everyone plays a role in antibiotic overuse, the doctor also, the patient also, and the pharmaceutical industry also. So it is a combined irresponsibility, or needs to be combined responsibility. Whenever there is fever, we tend to take paracetamol as well as antimicrobials. Mostly fever is because of respiratory tract infections, in India at least, which could be viral or bacterial in nature, but it is mostly viral flu, which is self-limiting in nature. In 3 to 5 days it is going to subside on its own. All that you would need is a paracetamol, some steam inhalation, and depending upon the congestion, maybe some nasal decongestant. That's it. You do not need to prescribe antimicrobials unless it is a protracted infection, it is lasting more than 5 to 7 days, it is turning purulent. So these are indicators of a secondary bacterial conversion. Then you prescribe antimicrobials. There is no role for prophylaxis in viral flu. I'm going to skip the rationality of antimicrobials. That's a separate class in itself. Basically, whether we talk about fixed dose combinations or we talk about rational use of drugs, education is important. The patient or the population needs to be made aware that there should not be self-medication. Patients should not have their own antimicrobial kits. I had a hard time convincing my father not to keep small doses of drugs that he was prescribed as sore throat medicine, as diarrhea medicine. So they should not have their own antibiotic kits, that they take it as and when they desire in inappropriate doses or inadequate frequency. There should be emphasis on the right dose and the duration. So basically, and that's about the patient education, and then you also need to stay educated yourself with continued medical education. After you've completed your degrees and you are into prescribing, you need to stay up to date with the treatment resistance patterns, the availability of drugs, the alternatives, the standard treatments and their alternatives. You need to stay up to date with this information. So it is educate patient, educate yourself, and follow evidence-based medicine for good prescribing. If you have any questions, you can write to me or you can meet me in my office. My email ID is there on the website. It is drgupta.pooja@gmail.com. Thank you.